Now, ultimately, for OSA, the mainstay of treatment is the use of continuous positive airway pressure. What we try to do is that we use this machine at night, and this positive pressure basically split open the collapsed airway. And when this is done, then there's no longer a collapse, and we abolish the hypoxemia, abolish the sleep fragmentation, and it gets better. Now, for the patient, usually these machines are now costing around $6,000 to $8,000 Hong Kong. It requires a little bit of titration on our part in the hospital, or a patient can buy up to a little bit more money automatic machines. So machines that titrate night by night, few minutes by few minutes, what the patient needs in terms of the pressure it requires to open up the airway. For those that travel or wants a smaller machine, then there are more expensive machines that are now the size of an iPhone. It's heavier than an iPhone, but the size of an iPhone. Now, of course, a major problem with CPAP usage is compliance, and partly a lot of patients do complain of poor compliance due to dry air. So because we're pumping a lot of air in, creating the pressure, so they have dry, and these machines, you can actually add humidifier, whereas these relatively more attractive, smaller machines, you cannot add humidifier. So there are pros and cons for each. For the patient, ultimately, that does not want to use these machines or don't want to invest or whatever, there are a few less ideal options, for example, oral appliances. What oral appliances is actually very simple, a mouth guard sort of piece of device that the patient just wear at night, and it physically just hold the tooth or the tongue or both and the forward movement so that it prevents the soft tissue from falling back. Now, the problem with oral appliances is that it only works in around 30% of patients. We don't know who. So we need to do this, design it, tailor it, and then we need to test them again. And even if for those that works, it works by reducing AHI by the best around 50%. So if you have a patient with severe OSA and you give them that and they're the one that works, it still only treats it halfway. So it's not an ideal treatment. So it's a problem. There are still more invasive treatment along the way, but ultimately coming back to what we want to talk about today is, again, obesity, respiratory, and therefore we will arrive at the next question, does weight reduction help? Now this is two studies, and this is a study in a diabetic patient, which showed that if you have a weight reduction of around more than 10 kilograms, you actually reduce your AHI by around 7 to 15. All in all, this means that if you have a weight reduction like this, you can bring your obstructive sleep apnea down 1 grade in essence. The result seems to be a lot more remarkable in non-diabetic patients. So in non-diabetic patients, if you have a weight reduction of around 10 to 15%, the more the better, a dose-related relationship, then you can actually abolish most of the moderate obesity, abolish most of the moderate mild OSA, and at least reduce the severe OSA down to moderate or mild level, which gives you a lot more options in terms of treatment. Now, in terms of sleep medicine in OSA, if this were the end of this would be very simple. In patients that are very obese, then we come more to even more maladaptive physiology. So far we have talked about when patients have obesity, they have upper airway resistance that leads to this OSA. So this is what we have talked about. Now, what happens when the patients are very obese